Good evening, everyone, and thank you for joining us for today's webinar, Living with Myeloproliferative Neoplasms. This is organized by the Florida Society of Clinical Oncology, FLASCO for short. This is a member-supported state society that focuses on supporting and representing the oncology workforce for Florida. Together, FLASCO is the voice of oncology in Florida. Many of the individuals presenting and participating in this webinar tonight are members of FLASCO, and we appreciate them volunteering their time and effort. My name is Dr. Sofia Alfonso, and I'm a pharmacist at Moffitt Cancer Center. I will be serving as the moderator for tonight's webinar. Our topic today is living with myeloproliferative neoplasms. Our oncology experts will discuss the disease itself and treatment options, and then move on to more individual focus areas, including support for caregivers, advocacy, and MPN resources. We'd like to thank Insight for sponsoring this webinar and helping us share this important information. So before I begin, I'd like to let everyone know that this webinar is being recorded and your lines will be muted for the duration of the meeting. At the end of the presentations by our panelists, we will host a Q&A portion, and we encourage you to submit questions or comments via the on-screen questions box on your GoToWebinar panel. We will discuss as many questions as time allows. So first, I'd like to introduce our amazing group of panelists. I am so honored to be able to introduce them, and it will be a brief introduction, but please read their impressive bios in the meeting material that was emailed to you. The link to download the meeting materials is also in the handouts box on your GoToWebinar panel. Now I'd like to introduce our panelists. Our first panelist, Dr. Andrew Kirkendall, is an assistant member at Moffitt Cancer Center in the Department of Malignant Hematology. He primarily focuses his clinical and research efforts on MPNs, MDS and MPN overlap syndromes, and systemic mastocytosis, where he is dedicated to developing novel disease-modifying therapies for these rare diseases. Our next panelist is Dr. Sarah Tinsley, a nurse practitioner working in the Malignant Hematology program at Moffitt Cancer Center. She is a member of the International Nurse Leadership Board for the Myelodysplastic Syndrome Foundation. Her research focuses on evaluation and improvement of quality of life for patients diagnosed with hematologic malignancies. She is passionate about the care of her patients, and she has published and lectured in this arena over the past 14 years. Also joining our panel is Lisa Barakat, an oncology social worker at Moffitt Cancer Center in the outpatient malignant hematology program. Her primary role at Moffitt Cancer Center is working with patients and their loved ones in coping with a hematologic diagnosis through psychotherapy, supportive counseling, advocacy, and collaborative efforts with the medical team to optimize that psychosocial support. Our fourth panelist is Dr. Michael Diaz. Dr. Diaz joined Florida Cancer Specialists and Research Institute in 2011 and currently serves on its executive board and as the assistant managing physician and vice president. In addition, he serves as the director of patient advocacy for FLASCO and on multiple work groups for our national ASCO. He also serves on the boards of other organizations, including Community Oncology Alliance and National Cancer Treatment Alliance. Our final panelist is Lauren Walcott. Lauren graduated with a master's degree in social work from Wheelock College, now Boston University. Born in Massachusetts, she brings almost 20 years of experience working with children and families in a variety of child welfare settings. Lauren is now with the Leukemia and Lymphoma Society as a patient and community outreach manager. So thank you so much, panelists, for taking the time to share your perspective on the different facets that make up living with MPN. I'll now turn it over to Dr. Kirkendall to turn on his webcam and open with his presentation on the disease and treatment options.
Hello. Thank you very much, Sophia, for that introduction, and really looking forward to this interesting virtual MPN session so we can and hopefully have some good lively discussion at the end as well. So I've been tasked with talking a little bit about what an MPN is and how we treat it. The next half hour or so, I'll kind of go through that and try to cover as much as we can, even though it's certainly a topic that could cover a little bit longer. So, first off, when we talk about myeloproliferative neoplasms, these are certainly a long term to use to describe a group of diseases, and one that we need to focus on a little bit before we get into things. So, a myeloproliferative neoplasm, or an MPN, which I'll use to term these, is really an overproduction of blood cells in the bone marrow that's driven by some sort of mutation that occurs deep down in one of these blood stem cells. When these mutations occur, it leads to just an overproduction of these blood cells, and really that's kind of what defines a chronic leukemia. And so oftentimes patients will come in and ask whether or not their myeloproliferative neoplasm is a cancer. And the answer is yes, even though that's actually something that was debated in the early 2000s, but it is now viewed as a cancer. It is also a leukemia, as it is a cancer of blood cells. But we would kind of classify it as a chronic leukemia. And when we talk about myeloproliferative neoplasms, there's three main myeloproliferative neoplasms we talk about. We talk about essential thrombocythemia, ET, polycythemia vera, PV, or myelofibrosis, which can either be primary myelofibrosis, PMF, or prefibrotic myelofibrosis, or pre-MF. And that's a fairly recent distinction that's been made by the World Health Organization in their 2016 guidelines. So I like to view these as not necessarily separate diseases, but really a spectrum of disease that kind of starts with essential thrombocythemia and then kind of progresses through myelofibrosis, which is more severe or has a worse prognosis associated with it. So, when you start with essential thrombocythemia, this is a disease that's often just represented by high platelets. When you get to polycythemia vera, you start to think about high red blood cells, but also high platelets. And then certainly white blood cells can be elevated as well. And then when you get over to myelofibrosis, you talk about blood cell counts that can be high in some cases, but they can also be low in some cases. But really, the bone marrow starts to show scar tissue in this sense. And that's where the term myelofibrosis comes from. And this is associated with more symptoms, usually harder to treat as far as blood counts being too low. Some patients can be transfusion dependent. Spleen volume and spleen size can be increased, and overall prognosis is not as rosy as what we see with ET and PV. All of these diagnoses, all these MPNs, are associated with what we call driver mutations, or gene mutations that typically drive the disease. And about 90 to 95% of patients with ET, PV, and MF will have one of three driver mutations. The most common one is a driver mutation in JAK2, JAK2. That occurs in about 60%, 50 to 60% of ET patients, 50 to 60% of MF patients, and virtually 100% of polycythemia vera patients. There's another driver mutation in a gene called MPL, or MPL, which is actually the receptor that tells the body to make more platelets. And that occurs in about 5% of ET patients and about 5% of myelofibrosis patients. And then lastly, there are mutations in a gene called calreticulin, or CalR, and that happens in about 30% of ET patients and 30% of myelofibrosis patients. But those last two, the MPL and the CalR, don't typically happen in polycythemia vera because they don't have much to do with red blood cell production. So we've covered, what the three main MPNs are and the mutations that are associated with those. And I mentioned that they exist on a spectrum. So ET can actually transform over time and start to look more like polycythemia vera. It can also transform into myelofibrosis. Polycythemia vera can over time transform and start to look more like myelofibrosis. And then within myelofibrosis, there's an entity called prefibrotic myelofibrosis that oftentimes will turn into myelofibrosis. And then some people often ask, what's the risk of this turning into something like acute myeloid leukemia or acute leukemia? And the risk of that is, relatively rare, but definitely possible. The chances of ET or PV turning into acute leukemia is somewhere in the realm of 5 to 10% over the course of 20 to 30 years. But that number increases with myelofibrosis, whereby it's 10 to 20% over the same time period. And when we talk about these transformations, it's not necessarily the natural history of the disease to transform into acute leukemia. That typically happens when additional genetic insults occur, additional chromosome abnormalities, additional mutations that allow this disease to turn into something more unstable, more acute. And certainly that's something we don't want to happen. So going back over ET, and this will kind of frame our discussion that's upcoming as far as how we treat these diseases. With ET and PV, essential thrombocythemia and polycythemia vera, I mentioned that these are diseases largely diagnosed by high blood counts. So with ET, it's high platelet counts. With polycythemia vera, we typically have to have high red blood cell counts, but you can often see high blood counts as far as white blood cells and platelets with polycythemia vera as well. We typically diagnose these with a bone marrow biopsy in conjunction with those abnormal lab values. And what we worry about predominantly as far as treatment goes is that these diseases come with an increased risk of blood clots. And by blood clots, I mean blood clots in the veins, in the legs, and maybe sometimes in the abdominal veins. That can happen, especially as a concern in young patients. These can go to the lungs. We call those pulmonary emboli. But you can also see blood clots in the arteries, and those can be things like heart attacks or strokes, and those are certainly life-threatening. And we know these happen with increased frequency in these diseases, and so really our main focus of treatment is to prevent those from happening or decrease the risk of those things happening, and we do that in a number of ways. For essential thrombocythemia, we characterize patients' risk of having a thrombosis by whether or not they have that JAK2 mutation, because that goes along with a higher risk of thrombosis. We'll also ask if they're over the age of 60, because it seems that age actually increases the risk of thrombosis forming. And then we'll also ask whether or not they've had a prior thrombotic event. So folks that have had a prior thrombotic event are more likely to have another one. So those patients would be at a higher risk as well. With polycythemia vera, we use a similar stratification where we wonder whether or not a patient's had a prior thrombotic event, and we ask about their age being over the age of 60. We don't really ask about mutation in polycythemia vera because virtually everyone has the JAK2 mutation, so it's really an equivalent risk across the board. There's some other things that have been associated with thrombotic risk, which isn't as well shown. Things like white blood cell counts that have been high, a high allele burden of a JAK2 mutation, cardiovascular risk factors. So some of these things have been associated, but not as well documented. And really, once again, the focus of treatment, and we'll come to specific treatments with ET and PV, is to reduce the risk of thrombosis. In myelofibrosis, on the other hand, we have different ways of looking at things. This is something, a disease that I said was a little bit more acute, a little bit more challenging, with a little bit of a worse prognosis than the first two. And so oftentimes we're trying to figure out whether this disease in a specific patient is something where we would consider the risk, or consider a transplant, which offers a curative potential. And so instead of asking what the risk of thrombosis is, we're asking what's the risk of dying from the disease. And so oftentimes we're using prognostic models such as the IPSS or the DIPS, or these are different models that have been developed that look at various clinical and genetic factors associated with the disease to try to understand what the overall prognosis is. And that's important with myelofibrosis because the prognosis can vary widely. A so-called low-risk patient may have a prognosis of 15 to 20 years, and this is a disease that's typically diagnosed in people's 60s, so that means they're living into their 80s. Or a high-risk patient may have a prognosis somewhere in the order of 1 to 2 years, so that's obviously a lot different. So it's really important to kind of figure that out with myelofibrosis because you might be willing to consider more aggressive or risky treatment options if the disease is more aggressive or risky. once we figure that out, and let's say we don't go forward with the transplant immediately, then the treatment really is focused on the patient's symptoms and signs, such as if their blood count abnormalities are the problem versus if it's more associated with symptoms. So I'll come to treatment specifically in just a second, but once again, we're trying to cover overall the disease, and I touched on that a little bit. So going back to ET and PV, the focus of treatment would be mostly on the thrombotic potential, but once again, all MPNs can be associated with these disease-related symptoms. And the disease-related symptoms that we talk about, we'll also refer to them as constitutional symptoms. And these are classic inflammatory symptoms. They almost sound like you have some sort of a flu or a virus or something of that nature. And really it's because these symptoms are driven by these mutations, which ultimately these mutations lead to blood cell production and an inflammatory response within the body. And so you can think about these diseases as leukemias or cancers, or you can also think about them as inflammatory diseases, because that's really what they are. And patients will often complain of fevers, chills, fatigue, weight loss, bone pain, mental fog, not feeling present. And these are kind of classic symptoms that people also talk about when they have a virus, whether it's a cold or the flu or something of that nature. People feel like this, except they feel like this all the time. And that's why myeloproliferative diseases are such a challenge, is because we really have to figure out a way to return patients to feeling normal if possible, or as normal as possible. So now that I've talked a little bit about the symptoms, the risk of thrombosis, the risk of turning into leukemia, as well as the different prognoses across the different myeloproliferative diseases, I'll kind of go a little bit into how we approach treatment. And some of this will be a little bit redundant from what I talked about earlier. But I would say the general treatment comes down to 3 questions. And so the 3 questions I always ask are, first off, is this a disease, PV, ET, MF, that the attempt to cure would be worth the risk? So when I say cure, we only really have one curative option, and that's a bone marrow stem cell transplant, allogeneic, meaning coming from another person. And that's a really risky procedure. If you talk to a transplanter, they'll give you numbers like the risk of dying within a year of a transplant is somewhere between 10 and 20%, but it offers the potential for cure. And so it's really something that you have to kind of weigh the options there. And most myeloproliferative diseases, ET, PV, lower risk MF, are not worth that risk. But certainly there are cases of high risk myelofibrosis where that's a consideration. So that's the first question I ask, because certainly that's something that if the attempt to cure is worth the risk, we need to get that started. We need to talk to the transplant physicians. We need to bring them on board and move forward with that. The second question is, what current disease-related problem can I improve? So, what is bothering the patient the most? What is the biggest thing that they would like to change about their current disease? And, I'd like to change other aspects of their life if those are the things that are bothering them, but I'm not really qualified to do that. So I focus on disease-related things. So things like constitutional symptoms, a spleen that's enlarged that's causing problems. Sometimes when the spleen gets big, it pushes on the stomach, makes it hard to eat, can only eat small meals, pain, fullness, just abdominal discomfort. It can even push on other organs and cause difficulties there. Some patients will talk about refractory itching, wake up in the middle of the night itching, itching with hot showers, itching with any water that touches their skin. This can be something that seems almost minor, but also can be just absolutely life-wrecking if it's present. To just think about being itching all the time. Fatigue. This is, virtually 100% of patients with myeloproliferative diseases will talk about fatigue. That really impairs their ability to function the way they did prior to their disease. And it's interesting that sometimes these diseases take years to get diagnosed, but when you talk to a patient and you say, okay, well, how long, like when were you diagnosed? And they may say, oh, earlier in the year, I had a bone marrow biopsy that showed this. And you say, okay, well, how long have the blood counts been abnormal? Well, they've been looking at them for a few years. But sometimes you'll say, when in your life over the past decade or 15 years did things change? And they'll say, really, it was like 10 years ago. I just completely started feeling different. I didn't have the energy level that I used to have. And that's a classic story that patients tell. So, it really is, this fatigue is very disease related. Other symptoms that we try to improve, headaches, that can happen a lot with essential thrombocythemia as well as some of the other MPNs. And then symptoms related to anemia. So shortness of breath, chest pain, dyspnea, fatigue on exertion, lightheadedness. Those are things that obviously can be signs and symptoms of having a low blood count. And then the last question I think about is what future disease-related problems can I try and prevent? And so, we're actually not that great at doing some of these things, but certainly with ET and PV, we think about thrombosis, blood clots, heart attacks, strokes. Is there something I can do to try to prevent that from happening? Should we do something additional? Disease progression, PV turning or ET turning into PV, PV turning into MF, ET turning into MF, MF, and all of those turning into AML. Unfortunately, we don't have great ways that have really been proven to decrease the risk of these diseases progressing, but that's something that we're actively looking at and studying to try to figure out what is the right target to prevent these diseases from ultimately progressing to another. Sometimes we have to think about organ damage from iron overload in our patients that are requiring a lot of blood transfusions, because sometimes that can lead to just getting blood transfusion over and over can lead to different organs be affected by having too much iron on board. And then rarely we also get portal or pulmonary hypertension. This is high blood pressure in the veins that go to the liver and the lungs, and that can lead to ascites and liver dysfunction. It can also lead to shortness of breath associated with pulmonary hypertension. And so that needs to be something that we are aware of. And even though it's difficult to prevent those things from happening, in some cases, we need to be monitoring and taking care of those things when they do occur. So once again, the three things I think about is: one, is the attempt at cure worth the risk? Two, what current disease-related problems can I improve? And lastly, what are future disease-related problems that potentially I could prevent, or at least should I be monitoring for? With ET, when we talk about each one of these myeloproliferative diseases specifically, with essential thrombocythemia, as I said, the main focus of risk is to prevent thrombosis. At the same time, we're also trying to improve symptoms and make sure that people are not struggling with the symptoms of the disease. So off the bat, we talked about that JAK2, age, and prior thrombotic history being the risk factors that we would look at to consider someone being high risk versus low risk. In a low risk patient or a lower risk patient, we typically say aspirin, a baby aspirin once a day, sometimes twice a day in patients that have cardiovascular risk factors is protective and can actually reduce the risk of having a thrombosis. And there was actually a large study that looked at the impact of aspirin in patients with ET. Next, we have patients that are kind of on the higher risk, and so in addition to aspirin, we'll often add something we call cytoreductive therapy, meaning something that'll kind of normalize the blood counts or get the blood counts to come down, but often these agents act in different ways. The classic cytoreductive therapy that we use is something called hydroxyurea, which is a really old medication. It's a pill, it's cheap. But what it does is it helps to bring some of the blood counts down. So it'll bring all the blood counts. It'll bring the platelets down closer to normal range. It'll bring the hemoglobin down. It'll bring the white blood cells counts down as well. But the more we study hydroxyurea, we realize the impact is not necessarily associated or strictly because of its impact on the blood counts. There's actually impacts that hydroxyurea has on the blood vessels that allow them to relax and likely play a role in why there's less blood clots. And so that's why we push for this additional layer of protection, such as hydroxyurea. Now, there are additional cytoreductive therapies that we'll use, and one of those that's becoming increasingly popular and increasingly interesting is something called interferon. This is something that people are even talking about now in the area of COVID. But interferon is one of our first immune therapies that was developed a long time ago, and even in the 80s and 90s was used for CML, chronic myelogenous leukemia, as well as hepatitis. Interferon historically has been given at very high doses, 3 times a week in the muscle, and is associated with a lot of side effects, flu-like symptoms, depression, liver dysfunction, to name a few. But increasingly, we've come up with better tolerated treatments of interferon, where we give it subcutaneously once a week or once every 2 weeks in some cases. We give much lower doses. It's pretty well tolerated. We still do keep an eye out for things like mood changes and liver dysfunction, but those are pretty easy to monitor for. And we counsel patients really extensively on that, and certainly jump on those things if they do occur and stop the medication. But This is a medication now that's being increasingly looked at in Europe, at least most recently, in the form of a formulation called ropeg interferon that's of interest. And ropeg interferon is an even longer acting interferon, where it's given once every 2 weeks, and has been studied specifically in polycythemia vera, even though now it's being looked at in essential thrombocythemia, and has really shown impressive results as far as blood count control, and symptom improvement even in patients. And I think it's something that's exciting that's coming on the forefront. The real exciting thing that we get, maybe a little too excited about until we can explain it more, is that in some patients on that ropeg interferon study, and then even in some in the pegylated interferon, albeit a minority, we're actually able to reduce that JAK2 allele burden from being very present to, in some cases, being very hard to detect. And so we think that maybe in some cases this has disease modifying potential. However, it's not the vast majority where that effect is seen, and certainly we can't count on that. So we do need to know more about it, but these are really encouraging things that are coming down the pipeline. Other than those cytoreductive therapies, I think we've talked about the mainstays being hydroxyurea and interferon. Anagrelide is one that's been historically used. We don't use it as much anymore. It's not as well tolerated. It's purely a platelet medication, but that is still used occasionally in some instances. Ruxolitinib or Jakafi is not approved for the treatment of ET, but in some cases where ET and PV have a crossover and there's a large symptom burden, that can be something that's considered, since we'll talk that ruxolitinib has a strong role in symptoms associated with myeloproliferative diseases. So moving on from ET to talk a little bit about polycythemia vera, it's very similar as far as how we approach it. Once again, the main goal is to prevent thrombosis, which is blood clots in the arteries to the veins. You're low risk if you've never had a thrombotic event before and you're under the age of 60. You're high risk if you had either one of those things. Low risk patients will do that aspirin, that baby aspirin. We'll also do phlebotomies, which seems very historic, I guess, to do this, but we don't use leeches, but we do drain the blood, and we'll drain the blood to try to keep this hematocrit less than 45%. And that's because there was a big study that showed that when we keep that blood a little bit better controlled, the hematocrit less than 45%, people have less cardiovascular bad outcomes as far as blood clots and heart attacks and things like that. So we think it's protected to keep this at a lower level, maybe make the blood less thick. So we do that for everyone, low risk, high risk, no matter what. We'll also make sure you're not smoking, because you don't want to add something else to the mix, and make sure that your other cardiovascular risk factors that would put you at higher risk for stroke or heart attack are well controlled, such as diabetes, high blood pressure, hyperlipidemia, because certainly, we could do our best to control polycythemia vera, but if you're smoking like a chimney and have uncontrolled blood pressure and type 2 diabetes, you're still going to be at risk for some of these outcomes. So we got to take care of the whole patient, not just our part. But in high-risk patients, in addition to all of those things, we'll also talk about doing that cytoreductive therapy. And once again, mainly I'm talking about hydroxyurea, pegylated interferon or interferon, typically in younger patients. And then this is where Jakafi or ruxolitinib becomes an option as well. Ruxolitinib is approved in the second-line setting after hydroxyurea in patients that are either resistant or intolerant, meaning that they're still having symptoms, still needing a lot of phlebotomies, their spleen's growing, or they're just not tolerating the medication because they have mouth ulcers or leg ulcers or something that it's a side effect that makes it very difficult for them to take the hydroxyurea. In those cases, ruxolitinib or Jakafi has been studied and has been able to show a number of benefits. One, it's been able to reduce the size or reduce the need for phlebotomies in patients that were still needing them, and we call that good hematologic control and phlebotomy-free outcome. It's also been able to show to reduce the size of the spleen, which is going to be obviously very beneficial. And then it's also improves quality of life symptoms. So things like fatigue, mental awareness, spleen related symptoms such as abdominal bloating, fullness, abdominal pain. Those things get a lot better with ruxolitinib too. So that becomes an option. And certainly in the second line setting and for symptomatic polycythemia vera patients, especially those that have itching, really refractory itching, ruxolitinib can be very good in that setting as well. So that becomes an option within the polycythemia vera group. Once again, ROPEG interferon, exciting within this group. Hopefully we'll have some access to it over the next year or two. That's a development story that's ongoing, so stay tuned. The next one we'll cover, because we have a few more minutes to talk about it, is myelofibrosis. Myelofibrosis is certainly probably the most complex as far as how we approach treatment. I think that we kind of skipped over the curative option with polycythemia vera and ET for good reason. It's very rarely is it worth it. These diseases have prognoses that are in the 2 decades and up. And so taking that 1 in 5 chance of dying from a risky curative procedure doesn't seem worth it. But with myelofibrosis, we start to entertain that option because some of these cases can be quite scary. As I said about the different risk scores, we look at factors like anemia, high white blood cell count, constitutional symptoms that I'd mentioned before, increased immature, almost like leukemic cells, we'll call blasts. If those are floating around, that's a risk factor. As well as things like low platelets, gene mutations, and genes beyond what I already talked about that we know can convey a little bit of a higher risk of the disease. We look at all of that and determine whether or not a patient's higher risk or lower risk. Higher risk patients, we'll talk about transplant. Lower risk patients will typically kind of take a similar route as the PV and ET, which is, okay, what's bothering you the most? How can I help the best? And for the non-transplanted myelofibrosis patients, we'll often say, okay, what is the biggest issue? And typically, to roughly put it, we kind of branch people into 2 different categories. One, they're people that have a lot of signs and symptoms of the disease that are either associated with their spleen or they're these fevers, chills, night sweats, and those things. The other group is people that don't really have the big spleen that's causing problems or the fevers, chills, night sweats. They're more having problems with their blood counts being too low, so anemia, requiring transfusions, low platelets, and then symptoms that come along with that, coming in for frequent transfusions, shortness of breath, dyspnea, fatigue, and in that case, we'll kind of focus our treatment on going after the anemia. In the first group of patients, we have fantastic agents that have been approved that really help to reduce the size of the spleen pretty rapidly and improve disease-related symptoms. And those medications are called JAK inhibitors, which is a little bit misleading because they work whether or not you have that JAK2 mutation or not. They work for patients with CALR, MPL, or JAK2 mutations. And really, these are things that block that heightened inflammatory process that's going on. I said that these can be looked at as inflammatory diseases that upregulate these inflammatory pathways. Well, JAK inhibitors can be almost looked at as anti-inflammatories because they kind of cool that down, and in doing so, they reduce the size of the spleen and improve disease-related symptoms remarkably. Even in the early studies that they got these drugs approved for at least for ruxolitinib, these trials that were called the COMFORT trials, it was actually shown that patients who got treated with ruxolitinib had better overall survival compared to those patients who didn't get ruxolitinib. Actually, with even more interesting, they randomized to 2 groups, and the group that got ruxolitinib initially lived longer than the group that didn't get ruxolitinib, but it was allowed to get it after 6 months. So that 6-month window actually makes a difference. So starting appropriate patients, meaning patients that have big spleens or a lot of disease-related symptoms, higher risk disease, on ruxolitinib early on is really important for getting good outcomes. And it's not because ruxolitinib is curing the disease or getting the disease to go away or getting rid of these mutations, but it's making patients feel a lot better. It's making them healthier. It's shrinking their spleen. They're able to eat more. They're becoming more nutritionally optimized. This is why patients are living longer on these JAK inhibitors. And so that's our mainstay of treatment. The other JAK inhibitor was just approved in August of last year. It's something called fedratinib. The brand name for it is Inrebic. And this was a drug that was studied actually around the same time as ruxolitinib, a little bit later. But the actual development and the approval process took some time due to some development concerns regarding encephalopathy that occurred in 1% of patients that were on studies with fedratinib, and largely that's been looked back on and said it was likely due to some other factors in most of those cases, but there is still a black box warning and concern with giving fedratinib, so we monitor for any kind of encephalopathy, and specifically we check thiamine levels because sometimes these vitamin levels may be contributing to that. Fedratinib also has a little bit more GI toxicity, diarrhea, nausea, and vomiting than we see with ruxolitinib. So ruxolitinib, despite the approval of fedratinib, is really continue to be the mainstay of treatment for patients with big spleens and disease-related symptoms, even though we do have multiple options now. On the other hand, you have that group of patients that have more low blood counts or anemia, and ruxolitinib and fedratinib aren't great options there because they typically worsen the anemia, even though it's a little bit temporary. It kind of drops and then comes back up a little bit, but it typically worsens the anemia and can cause worsening thrombocytopenia. So for patients who don't have big spleens and don't have symptoms but have low blood counts, those drugs don't do a ton as far as health goes. For the patients that have those anemia symptoms, we typically look at agents like erythropoiesis stimulating agents, things that kind of bump red blood cell productions. Lance Armstrong's a big fan of those. Things like Procrit or Aranesp, and now there's a lot of biosimilars that are similar to that. We look at androgen agents like danazol that are almost like testosterone derivatives that can boost red blood cell productions. And then we look at agents like thalidomide or lenalidomide. These are old agents, obviously associated with terrible birth defects, would use for morning sickness, but actually can help for red blood cell production. And we use actually still in myelofibrosis patients. And we've had really excellent outcomes in a subset of patients that really can stimulate red blood cell production, make them free of transfusions and overall feeling well. Overall, when we talk about using things to help red blood cell production, I would say that we're not where we need to be, and that's an active area of research. So I often will push for clinical trials in that setting because I think we need to develop newer agents. Because when you're saying that one of our best options is thalidomide, you know that there's work to be done. And then aside from the anemia and the spleen symptoms, sometimes you have more aggressive disease that looks like it's turning into acute leukemia. And then we'll look at agents that we use for leukemia like Vidaza or azacitidine or Dacogen that can help to try to get this disease under control, and sometimes can help to bridge these patients to a transplant as well. So that's kind of a brief rundown of the treatment. So hopefully you guys got a little information about what myeloproliferative diseases are, as well as how we think about treating and how we execute that plan. The last thing I'll touch on, just because I was asked to touch a little bit on the organization of care, because I know a lot of people who are listening into this may see a specialist and see a local provider like Dr. Diaz, and the question is, how do we coordinate that care? And I would say that first off, it's different, and it's certainly a work in progress, but I think that the relationship that I have and the relationship Dr. Diaz has, with our coworkers and our colleagues is really one, especially for this disease, is one of kind of mutual respect. And so I often tell patients that drive 3 hours to see me to talk about polycythemia vera that I really appreciate them, one, coming to talk about that. And then after we talk about the disease and everything for an hour or so, they'll say, okay, well, should I keep seeing my guy locally? And I'll say, absolutely. The guy's right there. He can do labs. He can look over everything. He can let me know if anything's going wrong. He can execute the plan. He's there. He's your first line of defense. If something's good there, you want someone local. You want someone right there to help you out. And they'll say, well, he didn't know as much about it as polycythemia as you did. And I was like, well, I would hope not, because this is really the only thing I do, and it's my job. But at the same time, you wouldn't drive all the way here to ask me about colon cancer or breast cancer or lymphoma or anything like that, because I wouldn't know the first thing about what to do about that, because I've left that in the rearview mirror a long time ago. And so I think that coordination is necessary. And increasingly we're doing it through different modalities, whether it's texting or calling or email or whatever it is that gets us on the same page so that we can coordinate that care. And despite us doing that and organizing that, I think that there is some, I would encourage patients to be their own advocate. And I know Moffitt has a portal you can go on and print off your note. I can write the note, it'll be in that day. You can print the note off and you can take it to your local provider. You can do the same thing with theirs. And you can say, hey, this is what they said the last time, here it is, and you can kind of force that communication as well. So that was kind of a brief foray into how this we kind of coordinate the care, but we're more than happy to do that, and certainly we even prefer to co-manage these things, because I think there's something that both parties bring to the table. So with that, I will mute myself and get off y'all's camera and pass it along down the line. But thank you guys for listening.
Thank you for sharing your insights, Dr. Kirkendall. I'd like to remind all attendees that if his presentation sparked any new questions or comments that you'd like to share, you are welcome to type those in the question box, and I'll read as many as we can during the Q&A portion at the end of the webinar. So now I'll turn it over to Dr. Tinsley to discuss management of MPN symptoms and quality of life. Dr. Tinsley?
Hi, thanks a lot for inviting me to share your evening with you. And I'm very grateful to Flasco for putting this on. I take care of a lot of MPN patients. And that was a wonderful presentation by Dr. Kirkendall. I am not a medical doctor. I'm a nurse practitioner. I'm a quality of life researcher. And that's what my PhD is in quality of life. And it's really wonderful that we have effective therapies for alleviating symptoms, even though we still have a ways to go. But I really like to get to know the patients and follow them along with their journey and really, you know, find out what is bothering them, what their value systems are, and then, you know, try to align their treatment with their goals. And so that's what we try to do, is individualize your therapy. And we can only do that if we really know you and know your disease. So the more you know your disease, and we can teach you about your options, and then we can get to know you, then we can put those two together. And we're really striving for optimal symptom management. If you feel terrible, you can't have a good quality of life for the most part. If you have horrible itching or a huge spleen, that makes it difficult for you to eat. And really, that's what we mean by improving quality of life, by managing the symptoms related to your disease. And that's where we get into shared decision making. When you understand what your disease is and what the journey is going to look like, and really pay attention to your symptoms, I found out that over time, I've been seeing patients in this clinic for a long time at Moffitt, that patients get used to their symptoms and then don't want to sound like a complaining patient, but we really do want to know how your symptoms are changing over time. And there are effective tools for looking at your symptoms and then going over them. And I think of like the frog in the water, like it gets warmer and warmer, and then the frog doesn't recognize it. And then it can be a bad outcome. When we're aware of how your symptoms are changing, then we can intervene and help you out. And that gets back to improved communication, you know, establishing that relationship so that you feel comfortable sharing what's really bothering you as far as symptoms with your medical team. So we can go to the next slide. So you are the key member of your healthcare team, along with your local doctor and your MPN experts. This is a symptom assessment tool. It's called the Myeloproliferative Neoplasms Symptom Assessment Total Symptom Score. And it goes through, there's just 10 questions, and then you answer them. And then if we keep a running log of those, you can see how they change over time. And this really assists the healthcare team in helping you to recognize how your symptoms are changing over time. So we can go to the next slide. So what are the common symptoms? I think Dr. Kirkendall covered this great. Fatigue, that's the #1 symptom, not just of myeloproliferative neoplasms, but all cancers. That's our #1 symptom. So if we could come up with an effective strategy for managing fatigue, we would really improve everyone's quality of life. Many of the studies have shown that moving is an effective way to decrease fatigue, not just in healthy people without cancer, but in cancer patients. If we can get you to move a little bit every day, that can help alleviate fatigue. Concentration problems is a common problem. Early satiety is really where you start to think of a big spleen. When a person starts losing weight and they're not trying to lose weight, then that's like a red flag for me that, you know, pay careful attention to feeling for an enlarged spleen, because it crowds out your stomach, like Dr. Kirkendall said, and it makes you lose appetite, and then you fill up quickly. And so you eat less and then lose weight. Inactivity is part of the disease. Night sweats, usually drenching night sweats, but many of the patients I take care of say that these are intermittent in nature, but they do disturb your sleep. The pruritus or intense itching, bone pain is part of the disease process too. And a lot of older patients think that this is just from arthritis. So sometimes it can be arthritis, but sometimes it can be related to one of these myeloproliferative neoplasms. The abdominal discomfort can be from an enlarged spleen or an enlarged liver. So that can come along, and then weight loss also related to an enlarged spleen, and fevers can sometimes occur. So we really, when we talk about goals of treatment, one of them, well, both ruxolitinib and fedratinib have been associated with reduction in spleen size and improvement in symptoms, using quality of life questionnaires to measure the symptoms. We also want to delay progression of your myeloproliferative to later stages of the disease. And in some cases, like Dr. Kirkendall said, cure is the goal, and you would achieve that through undergoing an allogeneic stem cell transplant. But you have to pay close attention to the risk and benefit ratio. You know, if you have a disease that's not, or an illness that's not causing you a lot of symptoms, and that you're going to live a long time if we can keep you comfortable, then the risk of transplant outweighs the benefit. Whereas if you have a more aggressive stage of the disease, then it's worth the risk if you have a good donor, and this is what your physician recommends. Again, you get back to what are your goals of treatment? Do you want to live as long as possible, even if you compromise your quality of life, or do you want to live, or do you want improved quality of life even if survival is shortened? So those are tough questions, I think, for a lot of people. So we can go to the next slides. With myelofibrosis, with polycythemia vera, we know that you make too many red blood cells. So anemia is the opposite of that, and is more of a problem when a patient has myelofibrosis, either post-polycythemia vera myelofibrosis or post-ET myelofibrosis. Then anemia is usually part of that disease process. And key to that is monitoring the blood counts. I would say that is common for all of these myeloproliferative neoplasms, is you get to know what your CBC looks like and what it should look like. And I do that by printing out patients' labs, and then I do a reference range, and we go through them, the white blood cells, the hemoglobin, and the platelets, and then look at what they should be. And then also look at that differential part of the CBC to see what type of white blood cells that are in the differential. And then recognizing what the symptoms of anemia are. Increasing fatigue is one of them, and shortness of breath, although there's other reasons for shortness of breath. And again, communication is the key with your healthcare team. One of the things that's really important is reviewing the medication list at each visit to see if there are any medications that are contributing to your symptoms, are ones that we need to discuss with your other healthcare providers and see if those can be adjusted. And then for other causes of anemia, we look at bleeding. Is there a chance that you're bleeding? I have had patients that had myelofibrosis that had relatively stable hemoglobin levels and then had a big drop, and that was related to some bleeding. And then nutrition. If you're losing a lot of weight and not eating, you could have a vitamin deficiency that's contributing to the anemia. We do transfuse as needed to minimize the impact of anemia. The thresholds more recently have been really lowered to a hemoglobin less than 7 grams per deciliter, which is pretty low compared to the normal. I try to make individualized transfusion thresholds based on what a person can function at, instead of just using a number. And then we involve the support of your whole team in the education. So your whole family members, everybody that supports you. Sometimes it's a neighbor, sometimes it's a spouse or a sister or a brother, but also get them involved in helping you with your fatigue or getting to and from appointments, things like that. So that's important. We can move to the next slide. And then we know that written communication helps reinforce what we're telling you. These are complicated diseases. It's not like telling someone they have bladder cancer or breast cancer. If you have a neighbor with that or a friend, then you know what that cancer is. But myeloproliferative neoplasm is difficult to pronounce and then also to explain. There are online resources. We have this MPN, Building Blocks of Hope, at the Myelodysplastic Syndrome Foundation's website. You could order a book that they would ship to you free, or you could download the online version and you can just go through it and highlight and make it your own book. There's also Voices of MPN. There's MPN Research, and then there's the Leukemia and Lymphoma Society. There is a patient that I see every week that has post-ET myelofibrosis, and she's involved in some online support groups that are confidential. I think she said she's in a private myelofibrosis support group that they meet online. And I think this is all of my presentation. Thank you very much for inviting me, and we'll move to the next person. Thank you.
Thank you for sharing, Dr. Tinsley. Lots of good information there. Next, we have Lisa Barakat to discuss caring for the caregiver, a role that is often overlooked when discussing living with this disease.
Sorry about that. I didn't realize I was muted. So I was saying thank you so much, Sarah, for your great presentation. I think the aspect of quality of life is so important, and sometimes not always discussed in the forefront. So I certainly appreciate that. So my name is Lisa. I'm one of the social workers in the hematology clinic, and I just wanted to introduce first the role of social work here at Moffitt, but also, probably in many other settings. First of all, thank you so much to Flasco for inviting me to present on the role of caring with the caregiver and the role of social work, because I think it's so important. So I wanted to first introduce the role of social work, because I think oftentimes, social workers are defined in many different settings differently. So for my role, we are there for emotional support and counseling for not only patients, but for caregivers, for family, across the journey. We recognize that living with a cancer diagnosis, especially MPN, can certainly contribute to so much anxiety, uncertainty, fear, depression. So just to name a few, it's certainly, we recognize that, and we're here to support you along the journey as you cope with the care continuum. So I think it's important to also talk about caring for the caregiver. So I'm going to spend about 10 minutes or so talking about caring for the caregiver, defining kind of who a caregiver is, and talking about some of the important work that you guys do. So I'm not sure if those who are in attendance are caregivers or just patients, but I think that both of you guys can benefit from kind of hearing a little bit about this. So I think it's really important first to define who caregivers are. I think traditionally a lot of people think of caregivers in the formal, in the formal idea, thinking of paid caregivers. I'm talking about informal caregivers. So those are family, friends, those who are not financially compensated for the care that they provide. The World Health Organization estimates about 4.6 million caregivers provide care to patients with cancer, and about 1/3 of those caregivers are actually providing care to 2 or more people. So not only are we talking about providing care to your direct loved one that is diagnosed with an MPN disorder, but also talking about maybe, caring for potentially an adult child or, for a parent, kind of those in kind of like the sandwich gap of, caring for their parents and still caring for their children. So research from the National Alliance on Caregivers estimates that about 72% of those caregivers, you guys are doing medical nursing tasks without prior training. So, you guys aren't trained medical professionals, but still we're asking you to do these, pretty complex things. And these things lead to caregiver burden. And when I talk about caregiver burden, I'm talking about burden that, the tasks, the burden is when the demands exceed the resources, whether it's directly or indirectly. So, unfortunately, again, you guys are tasked with doing these things that unfortunately you don't have prior training in doing. And that leads to burden, and that leads to burnout. And it can be very overwhelming, and you're, still needing to be there for your loved one and providing emotional support, providing care, and still, doing your daily activities and tasks. So when I talk about multidimensional burden, I'm talking about psychological, impacts. That includes anxiety and depression. We look at the care continuum and talking about how the rate of anxiety and depression is higher when you're first diagnosed, when your loved one is first diagnosed. And that's also with you guys as patients, your anxiety can be expected to be higher at diagnosis. And then typically when you're on treatments, it kind of levels out, and that's same for your loved ones, for your caregivers. But if anything changes, progression, that's again where it kind of spikes. Also talking about physical and medical burden. So a lot of times, your loved ones may be, coming with you to appointments. I know that's probably changed a lot right now in the life of COVID, but unfortunately, a lot of caregivers do miss out on their own appointments or push their own medical needs, because their primary goal is to care for you. And also the financial burden. Sometimes, your loved ones, depending on if you're in the retirement age or you're in the working age, either way, I think, it's recognized that there still is financial burden. You're either not able to work, the caregivers are either unable to work, they're working less, potentially, you're spending more money on your deductible or your, co-insurance, medications. So there's, we recognize that there's financial burden kind of all around. And also talking about existential distress, meaning that there's, sometimes a feeling of powerlessness that you may feel, whether, you're the patient or the caregiver, and also a sense of guilt, like, I could be doing something differently to help. And I think I want to normalize that, because I think that's kind of part of coping with this disease journey. But I encourage you to talk openly with us, and ask to talk with your social worker, whether you're a patient here at Moffitt, or you are seen in the community by a local oncologist. Connecting to help is so important. So talking about distress across the continuum, again, you know, I recognized how the anxiety and depression can increase when you're first diagnosed and kind of plateau later on when you're kind of going through treatments, and again, kind of can spike as you're living, as your, you know, maybe your disease changes. But for caregivers, a lot of times that can kind of remain at a higher state. So I think it's so important to, you know, to ask for help. So, you know, you can always, if you're a patient here at Moffitt, you can just say, hey, I'd like to talk with my social worker. Now, a lot of people may say, I don't have a social worker. Well, I can tell you that everyone here at Moffitt has a social worker. And in the community, I'm sure that your providers would be happy to connect you with someone. And that's also for, you know, for you guys as caregivers, you know, asking to talk with us. We're always available. You can reach out to us directly or through your providers. So I think it's really important also to talk about self-care. And a lot of people may laugh and say, oh yeah, I don't have time for that. You know, I'm so busy with, you know, caring for my loved one. Or, you know, I have many appointments and I just don't have time. But I think that just starting simple, because when I talk about self-care, I'm not talking about, you know, doing the expensive things. I'm talking about starting small. And just as you would schedule a doctor's appointment, I encourage you to schedule time for self-care and, you know, maybe starting small, you know, thinking about, you know, maybe just taking a walk or, you know, going to your, you know, your favorite read, something where it's doable, but you're blocking off that time so that way you're committed to doing that self-care to prevent that burnout. And then that way you can continue providing that support and care long-term instead of feeling so run down. Seeking professional help, there is absolutely nothing wrong with, you know, asking to see a therapist, seeing a counselor, or, you know, also, you know, asking to see maybe a psychiatrist to help prescribe medications to better control your anxiety or depression. A lot of people tend to think of anxiety or depression as something that is a stereotype and something that they're scared to talk about. But even though we can't see it, it still is important. You know, just like monitoring your blood pressure or any other physical symptoms, it's just as important in managing your anxiety or depression. What doesn't work, unfortunately, is trying to do it all. And I think oftentimes we kind of put on that brave face and we just kind of keep going and we keep going. But, you know, I like to use the analogy of the airport and putting oxygen on yourself before you're able to help others, because caregiver burnout is so real, whether you're, you know, extensively providing that hands-on care or just that, you know, going to appointments and advocating and navigating the healthcare system, that can be just as burdensome on you emotionally. So I really encourage you to reach out for help because we're here to support you. Also, pulling away and isolating yourselves and maybe not talking to, you know, your friends as often or your family as often, and even your loved one, the patient who's going through it. I think there's this false idea of, well, if I talk to my spouse or my significant other or my loved one that's going through this, then, you know, it'll make them more worried. I don't want to put that on them. And really, what that's doing is you're further isolating yourselves because I can tell you that you're both thinking about it, and it's so important to communicate with one another. And also not acknowledging your own feelings and your own concerns. Kind of sweeping under the rug is you know, a big thing that doesn't work when you're trying to cope with these stressors. So what are things that help for self-care? Again, being deliberate in caring for your mind, your body, and your soul. I know that may sound kind of cliche, but it really goes such a long way in not being selfish and deliberately, again, scheduling time to care for yourselves. I think that's so important. Because there are so many benefits of being a caregiver. to someone else. That's, one, providing care to someone you love. I think when you help someone else, it makes you feel good. And it makes you feel good when when your loved one is feeling good. And I recognize that that's out of our control sometimes, especially as you may not be feeling well. But I definitely believe that, providing care to someone makes you feel good. And also, you learn more things about yourself. You learn, the things that strengthen you and that benefit you, and it gives you purpose and meaning. So, I can't stress enough the importance of self-care and taking the time to reach out and ask for help. And again, that's what we're here for. We're here to support those needs. I believe that Lauren Walcott will be talking a little bit more about the financial resources that might be able to help with the financial toxicities. But other than that, I certainly appreciate the time and being able to talk a little bit on the role of social work and the role of caring for the caregiver with those diagnosed with an MPN disorder. So thank you so much for your time. And I'll hand it over to the next presenter.
Thank you for your presentation, Lisa. Once again, if you have any questions or comments that you'd like to share, you're welcome to type them into the chat, and I'll read as many as we can during the Q&A portion at the end of the webinar. So now we'll hear from Dr. Diaz, who will discuss patient advocacy. Dr. Diaz?
Yes, hello, this is Mike Diaz. Can you all hear me?
Yes. Yes, we can.
Okay, excellent. I apologize. Don't know what's wrong with my computer. It's not communicating very well with this software. I started off this morning at 7 o'clock with another webinar that I was speaking on, and camera worked just fine. So apologize for not being able to have any video on this, but I will try to keep things entertaining with the audio portion. So once again, my name is Michael Diaz. I'm a medical oncologist and hematologist, and I practice in St. Petersburg, Florida, with Florida cancer specialists. And so during the day, I see patients usually, but then I'm also a little bit busy on the administrative side of things. I'm the assistant managing partner and the vice president for the practice. But then also, one of the things that I started doing several years ago, 9-10 years ago by now, is that I saw that there was not a lot of involvement with healthcare providers involved in healthcare policy. And so I started doing that, starting working with Flasco many years ago, and that sort of evolved and snowballed. And so since then, long story short, now, after even being the president of the Florida Society of Clinical Oncology, I am now the director of patient advocacy, and I'll explain a little bit more about that in a few minutes. I try to represent the oncology patients in the state of Florida when it comes to advocating for them to have access to cancer care. I also do it at a national level. And when I say at a national level, I spend a lot of time in DC. I'm involved with a national organization called Community Oncology Alliance, and I'm the president of that organization. And we advocate for cancer patients to have access to high quality, affordable, value-based, quality-based cancer care that is close to home. One of the reasons why I do this, and one of the reasons why I'm involved, is that we have an extremely broken healthcare system. It's not serving the patients the way that it should. And yes, it is one of the best in the world, but still, it's far from ideal. In order to try to make sure that you're making the changes that you can, you've got to work at both levels, or have the ability to influence both levels. When I say both levels, state level and national level. National level in DC, that's where the vast majority of all your rules for Medicare come from. They can influence some of the Medicaid rules, but those are pretty much defined at the state level. So the state level is where Medicaid rules and regulations and policy is defined, along with commercial insurance. And so in order to be effective and to know what's going on and to understand the whole system, you've got to be involved with both ends of the spectrum. And so the main thing that I focus a lot of my extra energy and time on is trying to make sure that, once again, patients, they can have access to cancer care. I'm a firm believer that there's enough resources in this country that there's no reason why cancer patients shouldn't have to worry about having access to high quality cancer care that's affordable. They shouldn't have to worry about figuring out how they're going to pay for things. They shouldn't have to worry about, do I have to mortgage my house? They shouldn't have to worry about, can I eat, or can I afford to pay for these essential things? I think that there's enough resources. I just think that they're not properly allocated. And I'll go into that in just a minute. And in fact, the first thing that I'm going to start off, I could talk about a lot of things tonight, but I think I've only got an hour, right? No, I'm joking. I think I was given 20 minutes. I'm probably down to 15 minutes by now. As you've heard in the excellent presentations you've already had, we're starting to make a headway in cancer care with treatments, and it's predominantly through the use of a lot of very good medications that are being developed and coming out on pretty much, when you look at all of cancer care, on a continuous basis now. And that's great for patients, but on one hand, the other component that's not always so good is that they're usually not cheap. They're usually very expensive. And when you start unpeeling the onion as to why they are so expensive, it gets just a little disturbing. And this is a segue into what we're really going to be talking about. I don't know if all of you are aware, but a recent study has shown that approximately 50% of any drug, the cost of any drug, 50%, half the cost of any drug, is going to a middleman. It's going in the form of a rebate. It's not going to the pharmaceutical company. And we'll talk more about that in a minute, because that's actually disturbing, because the drugs are quite expensive. You can have medications, pills that you take every day. A daily pill can cost even $500. It's a little disheartening to know that half of that cost is going to a middleman. It's going to someone who possibly even wasn't an essential part of the process or part of your care. And so when you start peeling back the onion and as to understanding why things cost the way they do, it'll bring me into the thing that I'm really going to talk mostly about tonight, because I could talk for hours on end about all the different things we are unraveling. But I'm going to talk about a specific group of people, and they're called pharmacy benefit managers. And I spoke about them last time, and I'm going to speak about them again. And I'm going to continue speaking about them until we get to the form that we need. For those of you all not familiar with the term pharmacy benefit manager, these individuals are contracted by insurance companies, theoretically, to manage oral prescription benefits. They started off many years ago in the 70s and 80s. They used to just process claims for the insurance company. Your doctor gave a prescription, you took it to the pharmacy would submit it to insurance, they would give you the medication, and this pharmacy benefit manager would just process the claim. Simple as that. Well, they've evolved over time. They realized, wow, we can do a little bit more than that. And what they did is that they started managing the pharmacy oral drug benefits for insurance companies. And if you get an oral prescription, then odds are, I think in almost any case, unless you're paying out of pocket, it is being managed by a pharmacy benefit manager. Very rarely is it managed by the insurance company itself. And what they do is that they go to, let's see, first of all, these guys, they make their money by managing your benefits. How do they manage your benefits? Well, they set up contracts in between themselves and the pharmaceutical companies. And in the discussions that I have with the senior national executives of pharmaceutical companies, they're being approached. They have a new drug. It's a great drug, can benefit patients tremendously. The pharmacy benefit managers, they'll say, yeah, you've got a really nice medication. In order for it to have access to the lives that we covered, though, you've got to give us a 40% rebate, which means for each prescription that gets filled, the pharmaceutical company has to turn around and write a check to the pharmacy benefit manager for 40% of the total cost of the drug. And that's one of the reasons why the cost of the drugs is starting to get so expensive and why they're adding up. Why? Because that 40% is built into the cost of the drug. I'm hearing that on all levels, and that's becoming a universal thing. And just to give you an idea of how much influence these guys have, there are 3 large pharmacy benefit managers that essentially control the benefits for 80% of Americans. Okay? These pharmacy benefit managers don't exist in other countries. They exist in the US. And the system is becoming so convoluted now the pharmacy benefit managers are even buying the insurance companies. One large pharmacy benefit manager, in fact, one of the nation's largest, bought like the nation's third largest insurance company and now owns the insurance company. The other two insurance companies have turned around and bought the largest pharmacy benefit managers. And so there's a lot of vertical integration, and it's making it more and more difficult for patients to find adequate competition, for businesses to find good prices. There's a lot of consolidation in the market, and that's making it somewhat challenging. It's making it challenging on a lot of levels, and I'll give you some examples. Let's see, some examples how they can restrict the formulary. So on one hand, if the pharmacy benefit manager doesn't get an adequate rebate from a pharmaceutical company, then their medication, as good as it is, may not be accessible, may not be on the formulary. And I don't know if you know what a formulary is. A formulary is a list of the medicines that you can have access to for certain conditions. Sometimes it's just a list of drugs, and some drugs are not on there. You don't see what's not on there, you only see what's on there. And then sometimes the formulary can take another version in what's called step therapy, where you have to have tried certain medications first before you can try other medications. And then also sometimes they'll have what's called tiering systems in their formulary, in that, there's a lower tier of medication, which means your copay is lower if you choose from this bundle of options. But if you want this other bundle of options, well, then your copay is going to be a lot higher. So that's one of the examples of how the pharmacy benefit managers can sort of manipulate the system. Now, when you're dealing with an area, and I'm not belittling medical conditions such as high blood pressure, it's a serious condition, but for the most part, there are lots of different options that are available that you can use to treat this condition. Sometimes, yes, and a significant portion of the time, sometimes you have to use certain medications for multiple medical reasons. But when you have a lot of options for a very common condition, then you can have a formulary, and then maybe the majority of the time, 70–80% of the time, it's not going to necessarily impact the patient. Well, it doesn't work that way for cancer care. One of the things that we've been focusing on cancer care is precision medicine. We're trying to match the best medicine for the patient's condition, not only their type of cancer, but their specific type of cancer on a genetic level. And so you might have a medication that works extremely well for one type of cancer, but for one type of, let's say, breast cancer, but in another type of breast cancer, it doesn't work well. And so when you start having formularies, then it becomes difficult for cancer patients to be able to have access to proper medicines and the ones that will best manage their care. And we've got plenty of examples across the state of Florida where the pharmacy benefit manager will not approve a medication that a specialist, even a specialist, that one of my partners at Florida Cancer Specialists, they'll send the patient to Moffitt to get an expert opinion, and the expert at Moffitt says, no, you've got to start off with this drug. The drug that's normally first line could potentially cause a lot of problems in your unique health condition, and it could be dangerous for you. You need to start off with this other medication. The pharmacy benefit manager, we've seen where they will sit there and they'll deny, and it'll take 2 months to get an appeal approved to be able to give the medicine that will least likely hurt the patient. And that's just one example. Another example is that they will sometimes not worry about the timeliness and delay initiation of care. We've got plenty of documented examples where patients can wait 2 to 3 weeks easily to start a new medication whenever they should have started it quickly. We've got even some examples of patients having to appeal and wait 3 to 4 months before starting medication. I've even got a documented example of a patient that's died before she had a chance to get on her medication. We have examples where the pharmacy benefit managers are making medical decisions for doctors without having seen the patient. And let me describe a scenario to you. One of my partners had a patient with metastatic kidney cancer, and the kidney cancer had gone throughout his whole body. And the urologist, the surgeon, said, I can't do surgery on you. You need medical treatment. The medical oncologist agreed. We cannot do surgery on you. You need medical treatment. Well, it just so happened that at the time, the #1 oral pill treatment prescription was sent in for the patient, and the pharmacy benefit manager said, no, we're not going to approve this until the patient's had surgery, without having seen the patient. That's making a medical decision. I've got 2 other examples of where that's happened, one of them in a hematologic condition. So it's terrible whenever they feel they have the authority to be able to make medical decisions. And then there's all sorts of other things that they've implemented. Some of those are called like copay accumulators, to where if you are getting benefits or assistance from a pharmaceutical company or foundation to try to help with your copay that you have to pay, well, if it's not coming from your pocket, it's coming from one of these organizations, well, then your copay never goes away, even after a certain amount. Why? So they can keep on bilking money from these foundations and or pharmaceutical companies. So with that being said, part of what we do is that we try to accumulate evidence. So not only do we have bad patient stories, unfortunately, we got plenty of those. And in fact, if you wanted to read more, if you go to the website pbmabuses.org, it's a website that my organization set up where you can unfortunately see lists and lists of pharmacy benefit manager horror stories. But some of the things that we try to do, because we have to have evidence in order to try to get policy changed. I work with another organization who sponsored a study looking at Florida Medicaid. And the study was conducted by a very reputable group. And just looking at Florida Medicaid, just in general, medicines in general, they were unable to uncover some unusual things. And just to give you an idea, because the study is really complex and even complicated, and I had to read through it 2 or 3 times and I still don't understand it. It's like 100+ pages long. But just to give you an example, one of the things they found for a generic medicine that is used for very common psychiatric conditions, the pharmacy benefit manager was paying a regular pharmacy that they don't have a preferred contract with 24 cents a pill. And this pill is taken twice a day, every day. So 24 cents a pill. For the same medication, for a pharmacy that the pharmacy benefit manager had a contract with, and I've got my doing air quotes around contract, as a preferred pharmacy, they were getting reimbursed over $11 a pill. Well, it may not sound like a lot, but when you add up to that 60 pills a month per prescription, this prescription is written well over and filled well over 1,000 times a month. It adds up over time. So why is that discrepancy there? Well, we know that the one that's getting paid a lot more is the preferred pharmacy, but we don't have access to anything that's going on between them and the pharmacy benefit manager. Are there rebates going back to the pharmacy benefit manager? We don't know. But the study did set off enough flags in Tallahassee so that the governor's office has hired an outside accounting firm to do an audit themselves to see if they can validate this data and maybe possibly understand it a little bit more. And so we're hoping that we'd be able to get more momentum in Florida. We can get some momentum in Florida, that will help on some levels. And we're also working on getting more momentum in Washington. We go to the Hill several times before COVID. Pre-COVID, I was going to Washington 2 to 3 times a month. Last year, we had 2 trips where we took patients with these PBM horror stories to educate senators, to educate representatives and their staff so that they can understand what they're going through. And part of the other thing that we've seen is that just last week alone, the President of the United States announced some executive orders that he signed. And one of them had to do with Medicare patients. And it was to mandate, and we'll see how this unfolds. I don't know if it's going to work too well, but we'll see. It mandates that for Medicare patients that get medications managed by a pharmacy benefit manager, that all the rebates that the pharmacy benefit manager go toward the patient at the time of purchase, hoping to lower the cost of the drug and to lower your copay. So it was very interesting in the press conference. The president went on a tirade for about 90 seconds talking about these pharmacy benefit managers. I was hilarious because I haven't heard someone speak publicly so negatively about these organizations before, but that showed me that we were doing a good job of helping educate everybody in Washington about these pharmacy benefit managers. We're hoping that more will follow, possibly next year with a new president, possibly, new Congress, possibly a new Senate. But we want to continue working on PBM reform in Washington. We also want to work at a state level. We're already meeting with other organizations in the state of Florida to try to figure out our strategy for next year. We're hoping that we might be able to get some PBM legislation in Florida passed next year. And one of the reasons why I'm talking to you all about this tonight is that, you know, if you're interested in knowing what you can possibly to help us do at a grassroots level, those that can give either Julie or Amanda from Flasco their email addresses, will be glad to include you on a mailing list whenever we go grassroots, if we have to, at the next Florida legislative session, for you to reach out and contact your state representatives and or state senators to let them know to support certain bills that are pushing for PBM legislation and reform. We'll need your help at a state level, and we may also need your help at a national level. So if you are interested in helping out in any way, because our elected officials will sometimes only respond if they hear complaints from their constituents, no matter what the problem is, we may end up going grassroots and we might need your help. So please let Julie and or Amanda know that you're interested, and we'll be glad to hopefully put your name and email in our database so that when we go grassroots, we can send you an email and letting you know exactly how you can help us. And I think I've spoken a little bit longer than I should, but I appreciate everybody's time and attention. So thank you so much.
Thank you, Dr. Diaz, for bringing up these really important points. You were absolutely right on that vertical way that they are aligning themselves. They've also even started to purchase specialty pharmacies and make sure that business goes in that direction, which also delays treatment, unfortunately. So thank you for your strong advocacy on that regard. We will now hear from the final panelist, Lauren Walcott, who is going to share about patient assistance. Lauren?
Okay, hi everyone. And again, like everyone said, thanks for having me. I am going to talk to you about some of the programs that we have to offer with LLS. I'm sorry I don't have any slides for you, but I think the important thing for you to remember is our website, which is lls.org. And you can find all the resources that I'm going to touch upon there. And you can also reach us, reach our information specialists at 800-955-4572, and they're going to be able to also connect you to all the resources that I'm going to talk about with you today. So LLS, we do have financial resources in our agency, but due to COVID-19, our funds are a little stretched. So what some of the programs that we do offer, we have an urgent need program, we have a copay program, and we also have a travel assistance program. These programs, they fluctuate in and out, and so we usually email our social workers when they become available so that they're aware. But you are also able to check these funds too on our website. We also have a financial assistance number that you can call. So if we don't have resources available, they're also able to help you find some resources. And that number is 877-557-2672. And again, I hope that some of you received some of the booklets that we sent out a little bit earlier. But due to COVID, of course, we now more than ever really need to connect. So LLS is really focusing on our supportive resources. So some of the resources that we do offer online is something called our online chats. And we have these chats, they're set up weekly, and they're about an hour or so where you can log on and just chat with other people who are in similar situations to you. These chats are monitored by our social workers and nurses. We also have something called the LLS community. It kind of works like Facebook groups, so you can log on and really subscribe to all the groups that spark your interest, and then you will connect with others. You'll also learn information, and those two are monitored by our social worker and nurses. One of the things I'm really excited to share with you is we have something called our LLS Health Manager app. So you will now be able to find that on our website, but it's really an app for you, and it helps you track your symptoms, your questions for your doctors, your diet, daily activities. It's really just a way to help you organize just all of your needs. And so that is now on our website. So we are really excited about it. And you can download LLS Health Manager at the App Store or Google Play. And it's free, of course, for you. And again, it's just a great resource. We also have family support groups that are for our patients and caregivers. Due to COVID-19, all of these support groups are online. You have the choice of being on video or just dialing in, and you can find more about those on our websites. Now, we only have a few support groups throughout Florida, but that's why we also really urge the online chats. Then lastly, too, we offer our webcast. So once a month, we will do a live educational program nationally, and we will send emails out to you if you guys are part of our LLS database, where you can join a live program, hear from doctors from all over the United States. And then we also catalog those programs as well, just in case you are unable to reach them. Let's see. And so, yes, so those are mostly our services. And again, everything can be found on our website, and it's pretty easy. If you go to lls.org, you're going to see the Patients and Caregiver tab, and that's where you're going to find the drop down to all of the services I mentioned and more. And we do have a spot specific for caregivers. We do have something called the Caregiver Kit, which only can be requested by the caregiver by calling our information resource center. So they'll be able to send you a caregiver kit, but we also have online groups to support our caregivers as well. Another resource that's not connected with LLS, but it just is a lot of, which also has helpful information, is Voices with MPN, and you can find that on, you can find their website there. They encourage patients and caregivers to regularly evaluate their conditions and to raise their voice via informed, empowered discussions with their healthcare providers. Voices of MPN website also connects people to disease info, education programs, community activities, while inviting them to share their stories and spread disease awareness. And so, thank you.
Thank you. We so appreciate all of our panelists sharing all of their insights. It's such an important topic. We also wanted to note that in addition to the Facebook support group mentioned earlier, there's others out there, including one shared by one of our participants today called the Florida MPN support group. But I also wanted to take a moment before we transition over to the question center session to speak a little bit about the disparities that patients might also encounter. Cancer affects each person differently, and so it stands to reason that cancers can affect each population differently. But unfortunately, minority groups in the United States also bear a greater burden for many cancers. So the Florida Society of Clinical Oncology is actively fighting cancer disparities on many fronts. So on your cancer journey, you can do your part by making sure you just ask. Help us narrow the gap. To learn a little bit more about cancer disparities and MPN, please download our Disparities and MPN slide packet located in the Handouts drop-down box on your GoToWebinar panel. So I'll give you a moment to try and locate that, and in the meantime, we'll move on to the Q&A portion. We have a couple of questions that were provided before the session, and you're certainly welcome to please make sure and put in any questions that you may have. We'll certainly try and make sure that we cover all of them. So one of the questions we know was directed to Dr. Diaz. Dr. Diaz, this question, you talked a lot about the middleman profiteering. Possible that you could speak to a little bit about how citizens, especially MPN and other cancer patients, can help to get involved in making changes so that cancer drugs can be more readily available for patients?
That's a great question. Now, the only way that I can sort of answer to that is that in the big picture, if efforts are not coordinated overall, then there's so many little random signals that your voice gets lost in everything that's going on, okay? And so the best way that you can try to support things is to make sure that you are paying attention to like the Leukemia Lymphoma Society or FLASCO or any other advocacy organization, so that your name is hopefully on some sort of a list, so that if any of these organizations, because if FLASCO goes grassroots on something like this, I can tell you right now, Leukemia Lymphoma Society is going to be right there with us arm in arm, you know, and we will need to make sure that we are letting our patients know when their voice needs to be heard and what it is that they need to be expressing. Because otherwise, if you have your message, and I understand it might be a very good message, but if it's not coordinated with a political effort, such as a piece of legislation or other form of healthcare policy, then believe it or not, nothing usually happens from that. So I would just highly recommend that you pay attention to your advocacy organizations and try to get on mailing lists so you can see when you might need to respond and when you might, you know, and if also, you know, if you're on these listservs, so to speak, when, you know, you might see what topics are becoming large topics that might be of interest to you, and you can see how you may or may not get involved. But all the efforts really need to be coordinated whenever the time is right, unfortunately. Hopefully that helps.
Great, thank you so much, appreciate that. The next couple of questions are going to be directed to Dr. Kuykendall. So first one, Dr. Kuykendall, was you mentioned a lot about the most common mutations being the JAK2 mutation. There's this question asks about JAK kinase potentially helping not just patients with PV, but also in other diagnoses and maybe even in COVID infection. Do all cells have JAK1 and JAK2 components, and for the same purpose or for different purposes?
There we go. Yeah, so yeah, I mean, JAK1 and JAK2 are you know, encoded in every cell. But I think that when I was in my brief discussion, we talked that JAK2 is really involved in an inflammatory signaling pathway. And so, you know, you can have you can trigger inflammation from any cell, but it doesn't mean that the outcome's the same. So JAK2 happens to be involved in the production of red blood cells and white blood cells, and it responds to the signals that say make more red blood cells. But it's also involved in the signaling for inflammatory signaling. So if you have an infection or if you have an autoimmune disorder, they can faultily kind of signal through those pathways. They can signal through JAK1 or JAK3 or JAK2. And so even though the cause is a little different of why you have symptoms, so in the setting of PV or myelofibrosis, you have you know, a mutation in JAK2 that causes upregulated signaling through that pathway. And in an autoimmune disorder, maybe like rheumatoid arthritis, you have you know, an abnormal antibody that's causing stimulation of inflammatory pathways that then leads to joint pains and erosive arthritis. Just like in infections like SARS-CoV-2, you have a virus that triggers this massive inflammatory cascade that signals through you know, some pathways that may include JAK1, JAK2, JAK3. And so by using a JAK inhibitor, you can kind of settle down that pathway and stop that inflammatory cascade. And so that's the thought process for using this in COVID. But that's not new either. I mean, we use anti-inflammatories in infectious syndromes all the time, because we understand that sometimes it's not the virus or the infection that causes the problem, it's the inflammation triggered by the virus. And in some people, that trigger doesn't have to be too strong, and they can create a massive inflammatory cascade. And so if you look at all of it, I mean, I will say, before we say that Jakafi is a treatment for COVID, let's just pump the brakes a little bit. We've thought a lot of things are treatments for COVID. And just today, there was another study that came out looking at tocilizumab, which we use for cytokine release syndrome. They studied that, and everyone thought that was going to be really good for these critical ills, and that didn't seem to pan out. So there are, you know, first we have to test it to see if it's going to work out, and hopefully it does help people, and hopefully people live, because Jakafi helps to get these critical ill people to get to a better state. But that's the idea, at least the rationale behind it, because
what you're trying to block is the inflammation, and the inflammation signals through JAK, no matter if it comes from a mutation in JAK2 versus an infection versus an autoimmune disorder. So I hope that answered your question.
Great. Well, and kind of an extension of that same idea, the next question is also directed at you. Do you think patients on Pegasus may be somewhat protected from the COVID late-stage cytokine storm?
Yeah, look at this. I mean, all these things we use for who knew the key for COVID was going to be the treatment of myeloproliferative diseases? So I mean, I think that's really interesting, and I don't know. We've certainly talked about this as a group that you know, pegylated interferon is an immune modulator and can sometimes damp down that early inflammatory cascade from occurring. And you know, but what's interesting is how we're talking about using them in COVID is similar to how we talk about using them in myeloproliferative diseases. We're often talking about saving Rux and fedratinib, these JAK2 inhibitors, for late stages of the disease, higher risk patients, patients that clearly have symptoms, and then we kind of don't want people to use them in early phase disease where there's not too many symptoms because we're not sure how it's going to help. As opposed to pegylated interferon, now people are talking about using that to prevent infections from occurring, to basically not allow those things to happen, to kind of be and people are talking about inhaled interferon as a potential therapeutic option, even though early phase stuff, single institution kind of retrospective or kind of, you know, case series. But that's how we use it in myeloproliferative diseases. We use it in early myelofibrosis and in PV and ET, which are a little bit more. So, you know, I think that I'm certainly not taking my patients off of interferon. You know, if they're in a COVID hotspot, you know, that's not something I'd advise. Similarly, if patients are on ruxolitinib and they acquire COVID, you know, I'm not saying that we should really take it off because I'm not sure if that massive inflammatory release will necessarily be something that's tolerable. So, you know, time will tell if all these things are really effective or not, but I think it's interesting that there is good rationale for using these, and it's because of the experience we have with them in myeloproliferative diseases.
Very good. There's some other questions, but I wanted to pause one moment and just make sure that all the participants were aware. We talked about the mailing list in reference to several different things, is making sure that you get all the information that you would want. If you do want to be on the mailing list, you can submit your emails in the question box, and they are definitely making note of your email so that way you can get on these mailing lists. Okay, well, we have a couple more questions, and again, you can continue to submit those questions. We'll take as many as we can before the end of our time has run out. So I'll pose this to the panel. Here's one question, which is, I've had a knee replacement and have nothing but swelling to the upper part of the knee and not the lower part of the knee. I was diagnosed with PV in April of 2017. Could the PV have anything to do with this swelling, and is there anything I can do about it?
So my first thought is that unlikely that it has something to do with it. But if there was ever if you ever associated with the PV had a blood clot in that leg and it caused venous damage, then sometimes just damage to the venous kind of return can lead to swelling in specific areas. Oftentimes during a surgery, like a big knee surgery, you know, there is some damage to lymphatic channels or venous system that can lead to some swelling that may be asymmetric or just in certain places, and that's probably more so what it's related to than specifically polycythemia vera. Obviously, you bring up a good point, because in patients with polycythemia vera who are getting surgeries, knee replacements, hip replacements, there is an increased risk for blood clots and bleeding in surgeries, as well as clotting, especially orthopedic surgeries. So we definitely make sure you're consulting with, you know, prior to surgery I'm talking about, but consulting with your hematologist to make sure that there's a good plan and that the counts are controlled well enough to go to surgery, because oftentimes we want to make sure those counts are as controlled as possible, that you haven't just recently started on a new medication, that the orthopedic surgeon knows that you have a myeloproliferative disease, and so that there's a good plan for what the perioperative anticoagulation is going to be.
Very good. Okay, next question. an ET patient getting bone marrow biopsies. There's much debate these days on whether it's necessary to do a follow-up bone marrow biopsy upon diagnosis, especially with confirmation of a genetic mutation result. Should the bone marrow biopsy be a part of a complete evaluation?
Yes. No, so I think that I could have planted this question myself. I think that there's two questions. One, is a bone marrow biopsy necessary for a diagnosis of essential thrombocythemia? Not always. I mean, the answer is not always. Certainly, if you come in with high platelets, we can check a JAK2, a CALR, MPL mutation from the peripheral blood. And if there's no other reason for your platelets to be that high and everything's pretty consistent with that, we could certainly make the diagnosis without a bone marrow biopsy. That being said, I advise a bone marrow biopsy for virtually every single patient with ET, except for the rare patient who's very old or has a lot of comorbidities, and this isn't going to be a big factor in their overall health, in which case there's no reason to put them through that procedure. But for the vast majority of people, this is something we plan on them living with for 2-3 decades and doing very well. We don't have a cure yet, so we know that at some point, the disease may change, or your other health problems may change, the blood counts may change, how you feel may change. And at that point in time, we'd like the ability to do another bone marrow biopsy to compare it to what was initially done. I think that having that baseline is very important. The other thing is there's other diseases that overlap with essential thrombocythemia, or ET. I talked a little bit about prefibrotic myelofibrosis, which used to be a form of ET, but we kind of realized when you look at the bone marrow, there's some features that realize that this is a little bit more aggressive and is probably going to turn into myelofibrosis, and it's really a different disease, or a different part, or different kind of a stage of the disease, if you will. So that's not something you can really get a feel for without doing the bone marrow biopsy. And occasionally you just find other reasons in there. You may find some unexpected thing, and not be able to, you wouldn't have known that otherwise. So I do advise it for several different reasons. Is it absolutely necessary for every single patient? No, but you should do it.
Great. And I think I'm moving on to the last question. Can MPN symptoms be reduced by taking infrared sauna to promote heat shock proteins in the body? And also, can regular cryotherapy treatments also help relieve MPN symptoms?
I think you need to write, whoever wrote the question needs to start writing a clinical trial. I think this is interesting stuff. You mentioned heat shock proteins, which is actually a potential target of therapeutic, that has therapeutic rationale, by very, very well-adept researchers within the MPN field. So we're definitely looking at targeting heat shock proteins. And you're talking about things that do something to the body, that do something to the inflammatory cascade within the body. So, these aren't off the wall ideas or thoughts. This is what people and researchers are doing. I can tell you that there's researchers at UC Irvine that are looking at, common, there was recently a paper looking at N-acetylcysteine, which is, this kind of relatively common anti-inflammatory medication that in mouse models seems to be able to prevent thrombotic events from occurring. And so, it's while we have no information about infrared or cryotherapy and its impact in myeloproliferative disease, and I certainly wouldn't advise using that as a regular treatment without any data behind it. I don't think it's off the wall to be thinking about these concepts, because we need to be thinking about things that are not very risky, because we're not willing to accept a lot of risk with our treatments in patients that are going to live a long time, whose disease doesn't do too much, or has a low risk of transforming. But we need things that are low risk, that potentially can modify our body's way of dealing with inflammation. So while I don't think those two things have really shown, anything with proof, I think it's interesting to be looking at options like that.
Okay. Have one question here from the chat. Can you give a brief explanation as to how hepcidin, I'm sorry if I'm not pronouncing that correctly, is helping patients with PV?
Oh, it's not brief. So hepcidin's our master iron regulator, and there's an ongoing clinical trial, which this question is in reference to, that we actually have up and running at Moffitt, using a drug called PTG 300, which is a hepcidin mimetic. So it just basically looks like hepcidin, kind of acts like hepcidin. But in patients that have polycythemia vera, most patients are iron deficient at diagnosis because iron is a building block for red blood cells. You're trying to constantly make red blood cells, so you use up your iron store. You're like a builder that was, used up all the bricks and they're no longer there. At the same time, then to make things worse, we decided that our treatment's going to be that we're going to take blood from you with phlebotomies, which makes you even more iron deficient. So then you come in to see us and we're like, things look great. Your hematocrit's where we want it to be, and you haven't had a blood clot, but you're like, I feel terrible because I'm super iron deficient and I'm chewing on ice all the time. I've got restless legs. I'm fatigued. I have a headache. My hair's falling out. I feel awful. And you're like, but your blood count's looking. So the idea is that we have to figure out a way, because if we give you iron back, you're just going to make more red blood cells. And so the idea behind the PTG 300 or the hepcidin mimetic is that we can kind of maybe get into this, win both worlds type thing, where when you make a lot of hepcidin, you typically, in people that are iron deficient, then hepcidin will help to allow them to absorb more iron. So what we want to do, but then hepcidin is not only responsible for absorbing the iron, it's also responsible for dispersing the iron to the tissues that need it. And so the idea with a hepcidin mimetic is that in patients that are iron deficient, they'll be able to better allot their iron to the places where it needs to go, but also withholding it from the bone marrow, which uses it for making red blood cells. And so ultimately, what we are seeing is the potential to reduce hematocrits, reduce the need for phlebotomy, but also free up some iron for the rest of the body to use so you don't feel iron deficient. But the explanation is pretty confusing, and I think that the trial is very interesting, and we'll be interested to see some results this year at ASH, and whether it's virtual or in person. I think that'll be the first real look we get is in December.
Very exciting to have more options. Well, that was our final question, and I'd like to again thank all of our panelists for taking the time to share their expertise with us. This has been a really informative discussion, and I think we've all walked away with something new. As a reminder, this webinar was recorded, so if you missed anything and want to hear it again, it will be available on the Flasco website in the coming days. And thank you for attendees for joining us today, and we hope you will join us again for future webinars.
Thanks, everyone.